Alright, I'm going to move into another case here. This is a case that I'm going to call traumatic shock, and this doesn't have anything to do with electricity, but this is an 86-year-old male. He was charged by a bull, and he was knocked to the ground, actually, pretty violently, and on scene he was unconscious. He got intubated on scene, was pretty hypotensive, went to the nearest hospital, but then was pretty quickly transferred to our facility, and his blood pressure was in the 60s systolic, and he had received already some blood products, some fluids, and was actually started on vasopressin, or I think norepinephrine and dopamine at the other hospital, and those were running when he hit our facility when it was still hypotensive. The vasoactive agents were stopped because presumptively, of course, this is hemorrhagic shock, so resuscitation with blood and products is continued or initiated. Continue in our department. We're done all of the things you do in trauma patients. We're getting big lines in, we're double checking his airway, checking his chest, and of course we're going to do a fast exam. This is an unstable patient. This is the patient who you're going to save their life with your fast exam. Now this goes pretty quick because he was kind of sick. I'll point out a couple things here. So here we see some intestinal loops, and I don't see, pay no attention to these labels. Sick patients, labels get messed up. That's just how life is, you all know that. Some bowel loops here, but we don't really see any fluid around these bowel loops fairly closely. That's the Foley bulb. He had had a Foley placed prior to his arrival. And then here we see spine here. We're going to see a little bit of the kidney here. I think this is right side. And here we see the liver. We do see spine and a little bit of fluid in this patient's chest. And this is some probably squashed lung, maybe even contusion. Liver here, there may be a tiny little thin stripe of fluid right here under this diaphragm, but it's very scant, not a whole lot. And then we take some more views. So here we are on the left, and we see again the spine continuing in the chest. So even if you didn't see the fluid, which you see right here, that would be a clue that there was definitely some likely fluid or something in the chest. So there we go, fluid in the chest. But I don't really see any obvious fluid here. Maybe is that something, but nothing obvious. Not a ton of fluid in the abdomen so far. So we swipe through that a couple times. Back to the right, is there fluid? Let's look again. We're around this right kidney, not any fluid there. And then we quickly got views of the chest. Didn't look to be any pneumothorax, although we went pretty quickly through those. Alright, so questions. I intentionally left something out. What should his heart look like? If this is what most trauma patients are, hemorrhagic shock, what should his heart look like? Got a picture of it? You see it? It should be small left ventricle, right? Hyperdynamic heart. That's what the heart in someone in hemorrhagic or hypovolemic shock should look like. Small left ventricle, hyperdynamic. Now, this could be tamponade. We haven't seen the heart yet, so that's another etiology of shock, and that's possible. So here are some views of this patient's heart. So what we see here is a pretty poorly functioning left ventricle, pretty small, minimal opening of the mitral valve. It looks slightly tachycardic here, but we've got poor function in the left ventricle. We probably have some left atrial enlargement, but this is not what we expect if this is a patient in hemorrhagic shock, and there wasn't any significant pericardial effusion there either. So the full interpretation was there's no pneumothorax, no pericardial effusion, small pleural fluid bilaterally, and possible scant peritoneal fluid, but nothing huge, nothing really strikingly obvious. So, based on this FAST exam, the etiology of this patient's shock was thought to be more likely cardiogenic, and maybe this is myocardial contusion, a blunt myocardial injury causing cardiogenic shock. Could be coronary dissection causing an acute MI. Very less likely would be an acute MI surrounding this event, but probably trauma. So the blood was stopped, the products were stopped, and this patient was started on vasoactive agents and treated more like a patient in cardiogenic shock. And his hemodynamics actually did improve, and he was able to be taken for CT scan, which confirmed there was no major hemorrhage. Just showed some not too terrible pulmonary contusions, small amount of pleural fluid. There was a grade 2 spleen lac with a very small amount of hemoperitoneum, but no active extravasation, and really no other bleeding injuries. He was treated supportively, admitted to the surgical intensive care unit. He had an echo that day or the next day that showed an ejection fraction of around 15%, confirming a likely blunt myocardial injury. However, he did poorly. He developed multi-organ system failure, and he actually later died in the intensive care unit. But this case, as unfortunate as it was, could teach us some lessons about this patient and other patients in trauma. So if you think about causes of shock and trauma, we're all taught that the number one cause is generally hemorrhage, right? And hemorrhage has got to be what you think until you've completely ruled it out. And then you move on to there, you still hemorrhage. I mean, it's always hemorrhage is what you got to think is the cause of shock in your trauma patient until you've ruled it out. But there are other causes. They're much less common, but they are still there, and you still have to think about them. Obstructive causes like pneumothorax, we can usually pretty easily diagnose that on ultrasound. We can treat that pretty easily. Then cardiac tamponade, not that common, but should be diagnosable by ultrasound. Then there's abdominal compartment syndrome. That's usually a little bit later. That's usually not in the acute phase in the emergency department, but that's something on trauma patients, but more probably a delayed fashion. Then there could be cardiogenic shock, not that common in your trauma patients, but definitely can happen from cardiac injuries, blunt myocardial contusion, or coronary dissection, or also patients may have cardiogenic shock that made them pass out and wreck their car into a post office. And their trauma isn't really the problem. They have cardiogenic shock that led them to your emergency department. And we see those cases on occasion too. Then there's spinal shock, which I don't know directly how to diagnose on ultrasound, but if someone out there knows how to do that, please send me some info. And the point of all this is that not only can ultrasound help you identify locations of hemorrhage and hemorrhagic shock, which is most common in our trauma patients, but it can also help identify or rule out some of these alternative causes, which, although very uncommon, are very important and kind of dramatically change the way you're going to treat your patients. So if you haven't heard what I'm saying already, it's ultrasound all of your trauma patients.